Welcome, everyone. We are allowing just a few moments for everybody to join on. We will be with you shortly. Welcome, everyone, to this patient-focused webinar. I'm Shalene McHale with Insight Tech, and I'm pleased to be part of today's virtual education event. Please be patient as we take a few minutes to allow everyone to get signed on. The presentation will begin shortly. All right, it looks like we have a great number of attendees signed on, so let's begin. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. John Rolston from Brigham and Women's Hospital as he discusses focused ultrasound as a treatment option for patients diagnosed with essential tremor or Parkinson's disease. As questions arise during the presentation, please utilize the Q&A button. It's located at the bottom of your screen. We will have time after the presentation to answer these questions that are asked within the chat. So let me begin by introducing you to today's presenter, Dr. John Rolston. Dr. John Rolston is a neurosurgeon and neuroscientist at Brigham and Women's Hospital in Boston, Massachusetts. He's recognized internationally for his contribution to epilepsy surgery and movement disorder surgeries. Dr. Rolston received his bachelor's degree from Columbia University, where he won the Russell Mills Award for Excellence in Computer Science. For his PhD, he developed brain-computer interfaces for epilepsy at the Georgia Institute of Technology and Emory University. He received an MD from Emory University before completing his residency, training, and postdoctoral fellowship at the University of California in San Francisco. He has over 100 publications and has received numerous awards, such as the University of California's Harold Rosegay Award for Teaching and the Congress of Neurological Surgeons Basic Science Award for Stereotactic and Functional Neurosurgery. We are very fortunate to have Dr. John Rolston with us today. And with that, Dr. Rolston, the floor is all yours.
All right, thank you for the introduction and the opportunity to talk more about focused ultrasound. And so today, I'd like to talk about focused ultrasound for tremor specifically, and that means tremor for essential tremor, as well as Parkinson's disease. Again, I'm a neurosurgeon here at Brigham and Women's Hospital in Boston and Harvard Medical School. And with that, I'll start the presentation. So there are a lot of different movement disorders that people unfortunately have to deal with in the world. And two of the most common are essential tremor, which affects a lot of people over the ages of 40, 50, 60, and Parkinson's disease, which is another incredibly common disorder, usually affects people a little older than that. So let's talk about both of those individually. First, essential tremor affects about 2% of our population, so 1 out of every 50 people. Once you get to the older decades, so people older than 60, for instance, it's far more common. About 5% of people have essential tremor. Essential tremor is usually an action or a postural tremor. And what that means is an action when you're doing something like writing is when the tremor comes out, or when you're trying to maintain a posture like hold your hand still. That's when you see the tremor most. And it's usually around 6 or 7 or 8 beats per minute or per second is the tremor frequency you see. It affects men and women about equally, although women are more likely to get a head tremor than men are. And often it's a little asymmetric. So people might see the tremor a little worse in their right hand than their left hand, especially at the beginning. Usually affects more the dominant hand. So if you're right-handed, that's usually where people see it first versus their left hand or non-dominant side. And essential tremor, when it gets to be more advanced, you can sometimes have what's called a resting tremor, or when you're actually doing nothing with your hand, like resting it on your lap, you can still see a little bit of tremor there. Rest tremor tends to be otherwise much more common in Parkinson's disease than essential tremor, but it's not a clear distinction. There's a lot of overlap. Another thing that can happen a lot in essential tremor is balance issues. So a lot of people say that their balance at baseline isn't as good. And then some people say that their memory might not be as good as well. When you look at a lot of people with essential tremor, the vast majority, 85% or so, say their quality of life is worse because of the tremor than before they had the tremor. And about 15% of patients are seriously disabled by the tremor. So unable to do things like eat or use their phone or do the stuff they would otherwise want to do. The family history for the genetic part of essential tremor is very strong. So about half the people I see, and this is true most across the world, have some other person in their family with essential tremor. And this is actually stronger than you'd find for Parkinson's disease, where the hereditary part is maybe 10 or 20%. So Parkinson's is the other main source of tremor that we treat with focused ultrasound. So this is a different disease than essential tremor. This is a little less common, but still very common, affecting about 1 in 100 people over the age of 60. So that's about 1 million Americans right now that have Parkinson's disease. And there's about 60,000 new cases diagnosed every year. Men are slightly more likely to get or be diagnosed with Parkinson's than women by about 50%, but both genders can get it. There's the classic symptoms of Parkinson's, which is a resting tremor. So when the hand is resting, you might see a tremor. Usually we often see what's called a pill rolling tremor, where it's the thumb and finger that you might see, kind of like if you're fidgeting with a pill. Other motor symptoms you see of Parkinson's are stiffness. So the muscles are more stiff, and slowness. So the movements are slower than they were before the onset of the Parkinson's. But those are the three main motor symptoms. There's a lot of other symptoms that go along with it. And this graphic, which I really like, shows many of them. So there's commonly a more stooped posture, a masking of the facial expression, so a more stoic facial expression, softer speech, sometimes drooling or difficulty swallowing. There's sometimes bladder problems or constipation, muscle cramping, pain, a shuffling gait, sometimes freezing of gait where it's hard to get going or you get frozen in place. And then there's other ones that are more cognitive, like depression, fatigue, impaired thinking, or sexual dysfunction. All of these are part of Parkinson's. But the part that we're best at working with is the motor problems of it. So I'll skip that part. For medical treatment of these, so before we even think about surgery, we start with medicines. For essential tremor, there's one FDA-approved medication, and that's propranolol, which started as primarily a blood pressure and heart rate medicine. If that doesn't work, there's other medicines that are used, although they're not technically on label for essential tremor, like primidone. That's the other major one. Primidone started as an anti-seizure medicine. It's not very good at treating seizures, but it's actually pretty good at treating tremors for essential tremor. Up to about half of the patients that you try medicines on, whether it's primidone, propranolol, or some of the others, doesn't work, and they continue to have the disabling tremor. For Parkinson's disease, we don't use those medicines. We use a different medicine. Parkinson's disease is primarily caused, we think, by a loss of part of the brain that makes dopamine. So by replacing dopamine with levodopa, which is something that can actually go through the blood-brain barrier, that can help treat a lot of those symptoms. Tremor, though, specifically is one of the harder symptoms of Parkinson's to treat. And there are people where no matter how much of the dopamine you replace, they still have a really severe tremor that affects their lives. When those medicines don't work, we have a different way of treating the tremor, and that's with surgery. So we've known for decades and decades that there is a critical node within the brain that's involved in tremor. And this is somewhere inside the thalamus. So you have two thalami, one on each side, on the left and right. They're about the size of eggs in the middle of the brain, deep in the middle of the brain. Within each of those, there's a small little subnucleus called the ventral intermediate nucleus, the VIM. And that's a hub in the brain that connects the cerebellum in the back of the brain to the motor cortex. It's just a few millimeters in size. The size that's closest to it I found was an Austrian winter pea, so a tiny little thing. This has been shown to be overactive in tremor, whether it's from essential tremor or Parkinson's tremor. And we've known for decades and decades that anything you can do to stop that area from being overactive will help the tremor. So the ways we classically did this, first we would actually make a hole in the bone and put a probe down and heat up and burn this area. That's called a radiofrequency ablation. And we still do those sometimes. The other way that's much more popular or became more popular in the 1990s is deep brain stimulation, where you also drill a hole in the top of the head and place a thin wire into this area, but you hook it up to a pacemaker in the chest that stimulates that area electrically and shuts it down that way. Other people have done things like radiation therapy to this area to do the same idea. But what's really exciting is that in the last several years, we found a new way to affect this area without any incisions and any holes in the bone. And that's focused ultrasound. And that's the main topic of today, focused ultrasound. So ultrasound is sound waves that are so fast, so quick, that they're beyond the range of human hearing. So they're ultra, beyond that. Sound itself is just things moving. So whenever you're hearing sound, you're hearing oscillations, movement in the air around you in a frequency that you can perceive. But the other thing that is related to motion of stuff is heat. The more something is vibrating, the hotter it gets. So all sound, every sound that is going on around us is actually generating a tiny little bit of heat, usually not enough to do anything. One question they'll sometimes give physics undergraduate students is how long you'd have to yell at a cup of coffee to heat it up if it were perfectly insulated. And it would take about a year. But the idea is that if you can use sound at really high frequencies or high pressures, you can get more vibration and eventually more heat, enough to actually change how something works or to get rid of it by just using sound waves. Focused ultrasound does this with these ultrasound beams. And the way they get to a deep area of the brain without affecting the surface of the brain is by using a lot of different ultrasound beams. So the current system uses 1,024 beams, so that's 2 to the 10th power, a lot of beams of ultrasound, each one aimed toward that ventral intermediate nucleus of the thalamus, the VIM, that little Austrian winter pea-sized area in the brain, where each one of these 1,024 beams passes through the skin, the bone, the brain. On its way there, it's going to heat up that tissue just a little bit, but not enough to notice it. But where all 1,024 beams intersect, where they overlap, that gets so hot that it can actually burn and stop that tissue from being overactive and stop it from causing the tremor. This all happens within an MRI scanner so that we can see exactly what's being heated and how hot it's getting. This relies on discovery back in the 1980s of something called MR, or magnetic resonance thermometry, where you can use the MRI scanner as basically a really sophisticated thermometer of all the different places inside the brain. So as we're heating up the tissue in there, we can watch on the MRI scanner and see exactly how hot every little dot gets. And we can know that, okay, this little part got to be 51 degrees centigrade. We know that that part is gone and cannot cause the tremor anymore. We can also use this to look at areas we don't want to heat up and make sure that we keep our heating where we want it and it's not spreading to dangerous places. So here's a video of one of my first patients that I did this procedure on. And this was a few years ago now. But here you can see that this is happening inside the MRI scanner. The person has this helmet on their head with all those ultrasound transducers. And this is before we got started. So the tremor is still there, very present. You can see when he holds his hands up, it's shaking. We're treating his right hand. And we'll have him do some tasks like try to write on this piece of paper to see how much tremor, how much shaking there is in that writing. And you can see it pretty pronounced there, how much shaking there is. And then now we're going to skip ahead to after the patient's been treated, just a few minutes later. So this is the same guy about 20 minutes later, just doing a quick neurological exam. The patients are people that are doing this are wide awake, so you can talk to us. But now we can look at his hand, and that tremor is gone. So he's putting in different postures. The posture is gone. We're going to have him test his handwriting. You can already see how much more steady that is, how much more stable that handwriting is when he's doing this. So really clear that it was a big improvement in just moments on the focused ultrasound table. So here's an example of that drawing that he was doing before he started. So here he was trying to do a spiral. So to put a pen down on this paper and hold it within these lines and do a spiral, but couldn't do it. Couldn't keep the pen on the paper because the tremor was so bad. And then he tried to do write his name on it, and he couldn't do that either because, again, the tremor was so bad. Here it is just a little bit later, doing that spiral. Now you can see that he's able to keep the pen on the paper. He's able to draw a straight line. He wrote his name, but we blanked that out so you couldn't read it. But a profound improvement in that tremor in just minutes of this procedure. And here's what the MRI scan looks like before and after for this for a patient like this. So you can see the brain. This is that thalamus area deep in the brain where my mouse is kind of hovering, that arrow is. And then right after you see a little, what looks like a bullseye right there. And that's that small heating up and damaging that tremor causing tissue right there in the brain. So that's one patient, but overall, we've looked at this ourselves and elsewhere and looked at a lot of people to see how good of a result we get. So there's the first major clinical trial was headed by Jeff Elias, who's at UVA, but included people here in Boston. And they did, and we did thalamotomies or damaged this area in many patients. About 56 where we did this to treat the tremor, and about 20 where we had him hooked up on the MRI scanner in that helmet, but didn't actually do anything. We told him we were, but we didn't tell him, or we didn't actually perform the procedure. And these blue bars are the improvement of tremor for all these different patients. Each one is a different patient, and these red ones are the sham ones where we pretended to do it. And you can see that the ones we actually did it got a lot better in their tremor, and those we didn't really change. Since then, we've gotten a lot better since that randomized controlled trial. And now when we look at about the first 150 patients or so, we can see before, if you look at their tremor, a bigger number here is bad. Right after, their tremor gets much better, stays better over 90 days, which is 3 months or a year, continues to be good for all that follow-up. So much larger improvement than initially because we're getting better at it with all of the training we've done. Here at Brigham and Women's Hospital, we just did our 500th case earlier this week, so we've done quite a few of these. So what kind of side effects could you get from this besides the improvement in the tremor? You could have some side effects, unfortunately. When we're targeting this ventral intermediate nucleus, there's areas nearby that we don't want to heat up or injure. And some of those in this little drawing from Hassler in the 1950s show what those things might do. Right behind where we target tends to be a part that controls sensation from the face or hand to bring that to the rest of the brain. So when you create this lesion, when you get rid of those tremor cells, right behind them, if the lesion's a little big or causes pressure or makes some swelling on those, it can cause some numbness or tingling. Usually in the corner of the mouth or maybe the pointer finger or middle finger of the hand that you're treating. If the spot gets a little too big to the side laterally, it can get on what's called the cortical spinal tract, which can cause things like balance problems or sometimes a little slurred speech, which we call dysarthria. So a lot of what we do, and one of the reasons we do this with patients awake, is so we can test for these side effects. So we can deliver a little tiny dose of heat, enough to stun that part of the brain, but not enough to cause anything permanent. Make sure it's getting the tremor better, not causing side effects. And if so, we can do something more permanent. If we see a side effect like numbness, we can move that spot where we're pointing a couple of millimeters to stop that from being permanent. When we look at all of our patients, this is again the first 120 or so, and looked at the kind of side effects we saw. The very first day, the most common ones we saw were those that numbness, usually fingers or side of mouth, in about a quarter of patients, about 1 out of 4. When you look at patients about a month later, it's about a third. So there's some swelling, so it gets a little more prevalent. 3 months goes back down again. Then by a year, it's a little bit less than that. The most common one we see is imbalance. So people feel that when they're walking, they're a little unsteady on their feet. Not everybody, but a little over half of people. About a month, that goes down somewhat. 3 months, it's down even lower, down to about 1 in 4 instead of 1 in 2. And then about a year, it's down to, maybe 1 in 10 or so. So all these side effects tend to be mild. People are still walking. They just feel imbalanced. But they tend to get better over time as the brain kind of recovers from that swelling and rewires itself and retrains itself. Often we get asked about insurance coverage for this procedure, and luckily, because there's such strong evidence for it, so a lot of randomized controlled trials now, both for essential tremor and Parkinson's disease. Medicare has policies all across the country to pay for it. There are a few criteria they want people to satisfy before they pay for it, though, and most private insurers will follow this too. The 4 main criteria is that for essential tremor, that you have drug-resistant essential tremor. So you've tried medicines, at least 2 medicines. Usually that's propranolol or primidone. Sometimes it could be topiramate or gabapentin or one of the other seizure drugs that sometimes people use for essential tremor. But you have to have tried 2 medicines. The other couple, the next 2 are kind of the same, but slightly different. The second one says that you have to have a severe tremor, either in your dominant hand or the other one, on some sort of tremor rating scale. The companion criterion to that is that it has to be disabling. And we actually have these measures to calculate how disabling a tremor is that we could do on all the patients we see. And usually that means things like difficult to do things like hygiene or write or eat because of the tremor. If it's not disabling, if it's not bothering you that much, you could ask, why are you considering brain surgery for it? The last one, and it's a little more controversial, is that the insurance Medicare criteria say that you are not a candidate for deep brain stimulation, which they for some reason prefer. And that can be something like older age, if you're on anticoagulants like aspirin or Plavix, or if you have surgical comorbidities that might make open brain surgery more dangerous, or if deep brain stimulation didn't work. But if you satisfy those 4 criteria, and almost everyone does if they come to this stage, then you can get insurance to pay for it without much issue. Otherwise, it can be a little harder. You might have to appeal with the insurance company. There are a lot of frequently asked questions we get for these things. One of the most common is, how does it work for which side you do, and can you do both hands eventually? Initially, we only treat one hand at a time. So we start with the person's most affected hand. Usually that's their dominant hand. And then before you do the other side, you have to wait 9 months. So it usually, or it used to be that you could never do it per FDA, but they did another clinical trial to show that it was safe to do both sides, as long as you have some time to recover in between. And that's to let those issues like the balance problems or numbness recover. Make sure you're at your best before you go and try the second side in case you have more balance issues again. Another question is about implants. So a lot of implants are fine, things like artificial hips or knees. Heart pacemakers can cause some issues because some of them are not MRI compatible, and it depends on the MRI and the pacemaker. So here we'd have to talk to you and make sure that it's something that we could do in our scanner, but there's other scanners across the world that do focused ultrasound that can accommodate that. So usually it's okay, but it might mean that you have to look for a program that's in the region, maybe not ours. Can you do focused ultrasound if you already have deep brain stimulation? Usually you need to remove it before you do the focused ultrasound. Although we have done some cases where a person only has one side DBS and we do the other side with focused ultrasound. But we usually can't do, if you have both side DBS, it's hard to do focused ultrasound with that. Another very common question is head tremor or voice tremor. Head tremor and voice tremor, we don't go into focused ultrasound hoping to fix those. So if that's your primary concern, it's probably not the best treatment for you. It might be something better like Botox is more appropriate for that. Our best control for the tremor is the hand. So if that's a big problem, doing that's good. Sometimes we'll see a little improvement in the head or voice, but that shouldn't be the main goal. Another question is, how old could you be to still do this? Is there an age cutoff? And no, there is not. So whether you're in your 60s, 70s, 80s, 90s, that doesn't matter. This is so safe and low complications that it's easy to do this even if you're older age. So that's the bulk of the main presentation. But I see some questions in the Q&A, and so I can start answering those. And if anyone else has any questions, please either put them in the Q&A or ask them, and we can address those. So I can start with.
Oh, do you want me to read them to you so you can answer them out loud, or do you?
Sure, that sounds great.
Okay, so let's start with the first one, and I'm just going to remind everybody that's on the call, we do have a couple questions already in, but at the bottom of your screen, you see the Q&A. You feel free to put your questions in, and Dr. Rolston will try to get to those before we end the presentation. So the first one I have here is, I have read where I need to stop my blood thinners to have focused ultrasound. That makes me a bit nervous. Is it truly necessary to do this? If there is no incision, why do I have to stop them?
So that is an excellent question. We actually were the first ones to study this, and we have a paper out that was published a year or two ago where we looked at all of our patients and we did not stop any blood thinners. So we let them continue Plavix, Coumadin, whatever they were on, because just like you said, there is no incision here, so we're not worried about bleeding or hemorrhage. And we had no problems with this. Everyone did fine. We think it's actually safer to stay on the blood thinners. There's a reason that you've been prescribed them to prevent things like blood clots. So stopping them has its own risks. And because this is so safe, continuing to protect you from those clots, we think is the safer course of action. So in our practice, you do not need to stop them. There are some other more conservative practices out there where they do, but not for us.
So can we just piggyback on that maybe a little bit? So for people that are on medications, are there specific medications, Dr. Rolston, that they will have to stop? And is there a certain amount of time they need to stop them for? They might just have that question.
Yeah, so we let people take whatever medicine they want to through the procedure. If they can stop the tremor medicine the night before, that can sometimes make it a little easier for us to track the tremor during the procedure. So if you're on propranolol, for instance, skip a couple doses, or primidone. Although if the medicines worked really well, you probably wouldn't be getting surgery. So even if you're taking them, usually the tremor is still bad enough. So we suggest stopping those tremor medicines, but even if you didn't, it would still be fine.
One of the questions that I don't see on here, but it literally comes up for every single one of our webinars, is the idea of having to shave your head, right?
Yes.
And I mean, a lot of people are asking, like, why? Why do I have to shave my whole head, right? Can you just explain why that is, and the idea of like just not doing one spot or whatever for other things? Can you explain that?
Sure. So right now, to do focused ultrasound, you do have to do a whole head shave, which means all the hair goes off with some clippers, and then we use a razor blade to get it down to the stubble. And the reason we do that is when we deliver the ultrasound, we need those beams of sound to go through that transducer array into the brain unobstructed by anything. If you have hair, even small, short hair, it can sometimes trap little air bubbles when we have this conducting water medium around it. And those air bubbles, when they get hit with the ultrasound, can vibrate or break open. And that can ruin the ultrasound's ability to cause that temperature increase. So until we find a way to bypass that, which people are working on in the research realm, until we find a way to get around that, the only safe way to do this is to get rid of all the hair. So one day we'll have a way to bypass that. But right now we have to still.
Perfect. And then I'm going to ask you one other one that I know that comes up every single time. The idea of being claustrophobic. Some people, just the idea of going into an MRI, they're claustrophobic, and they may want this procedure, but they're nervous about it. Can you talk a little bit about how you handle that, and just maybe explain to them that, like, you're not in the MRI for an hour and a half?
Yeah. So we've never had a person, even people that say they're claustrophobic, not be able to handle this with no issues. And so just like you said, you're not in the MRI bore where you're kind of obstructed for a very long time. The longest part is the first 10 minutes or so when we do a baseline scan. So your head's on the table, you're in the ultrasound array. We slide the bed into the bore. We do that first 10-minute scan, and then we slide it right back out and talk to you. You're able to move your hands, your feet, anything you need to do. We'd have people there. You can get more warm blankets, whatever you need to be comfortable. Once we are ready to deliver the ultrasound energy, each time you deliver a volley of this, it's only about 10 to 30 seconds. So you're in the MRI, we deliver that little bit of energy, and then we pull you right back out. So you're only in there for a minute or so at a time. It's not a long period where you're in the MRI bore, that kind of obstructed part for hours and hours. It's pretty short bursts that we have to do it for.
Perfect. Okay, we have another question here. I'm deciding between DBS and focused ultrasound. Do you think that doctors are getting better at doing this compared to in 2016?
Yeah, so I know that people are getting better at doing this since 2016. So when we first started doing it, it was the first time. People had never had this technology to try before. And over the past 500 patients that we've done, we've learned ways to make it safer and better. And so one of the most obvious things we can see is when you look back at the randomized controlled trial that they initially did to show that this was effective, the average reduction in tremor was about 50%. So 50% less tremor. Now we usually get 80, 90, or 100% reduction in tremor. So we get much better control of the tremor. And we have that published in our series too. And we've also found ways to change where we're targeting or how we're looking at the brain to try to minimize side effects like those balance issues, which we think are less prominent now than they used to be. Also, numbness, which when we first did it was pretty common, much more rare nowadays. So initially it was about 1 in 3 patients. Now it's more like 1 in 4, 1 in 5, maybe even 1 in 10. So all these are getting better, and we're getting more effective at this as time goes on. And the technology itself is also evolving. So there's new updated versions of the software and hardware that the company makes that can make it easier for us too.
So I'm going to jump down a couple of questions because it kind of, is similar. This person's asking, can you share a little bit more about the pros and cons against DBS? So again, focused ultrasound versus DBS.
Yeah, so I perform both. So I am happy. I enjoy doing both procedures, and I have what I think is equipoise or a balanced view of both procedures. And I love doing surgery, all surgery, but I like doing these procedures in particular. So deep brain stimulation is where you put a thin wire into that same spot that we're targeting with focused ultrasound, except it's connected to a pacemaker in the chest. So one of the advantages of that is that it's not a permanent change to that part of the brain. There's a little damage whenever you put the wire in, but it's not as much of a lesion as you make with the focused ultrasound, where you're deliberately creating a little burning of that area. So it's more reversible is what we would say. You can also turn it up or turn it down or change the settings over time if the tremor changes over time. You have some customizability for it. And that's all good advantages. The disadvantage is that there are risks to doing DBS that don't exist for focused ultrasound. When you make an incision in the skin up here on the head or in the chest, you can get an infection. Some of those infections can be very serious and actually travel to the brain. That risk doesn't exist with focused ultrasound. Another is that you're putting this wire through a lot of normal brain to get down to that structure. And you could, it's possible, hit a blood vessel or something else and cause bleeding. So that unfortunately happens very rarely, but it still can happen and can be very dangerous or deadly if it were to occur. So those are some of the risks of the DBS that you have to put up with for that ability to maybe turn it on or off. And that's why we say that for DBS, we do have age cutoffs. We do stop anticoagulation medicines. For focused ultrasound, we don't do those because those things like infection, bleeding, stroke, we don't have to worry about those with focused ultrasound. So some pros and cons for both, and both have their place in our treatment.
So I'm going to go down a couple of questions again because I think we're on a roll here. Somebody else is asking, I'm assuming that I could have focused ultrasound then if they had DBS and they weren't satisfied with it.
Mm-hmm.
Is that true?
Yeah, so you can go either direction. So you could do focused ultrasound. And then if you decide that, it's not quite as much as I want, you could potentially go back and do DBS to that same area. Um, it's we haven't done much of that, but we have done a couple cases, and it's been fine when we've done it. But it's so rare that we don't have 100 patients for it. The other way I've done more of, where I've done DBS first, the person didn't like the DBS or had some complication with it, like a bad infection, and we had to take everything out and then go back for focused ultrasound. That one I've done many times, and that one also works fine too. So either way, it's you're not closing any doors with these things. You can always have other options for you.
Um, the next one we have is I have Harrington rods from T10 to the sacrum. Is this a problem for the focused ultrasound?
Yeah, so spinal fusions, instrumentation, hardware, all those are made to be MRI compatible in the last 20, 30 years. So that's not a problem for this. And a lot of people have had spine surgeries. So if we couldn't do it on that, we would have a lot fewer patients. But the Harrington rod should be fine.
And I mean, just to piggyback on that, one of the questions we get a lot of times is pacemakers, right? They're
Mhm.
wondering if they can have this done if they have pacemakers. Any kind of apparatus that's in their body is okay as long as MRI compatible, correct?
Yeah, so every device has their own indications, and we go through all those with anyone who's considering focused ultrasound. Most of them are fine. We might have to put the device like a pacemaker in a special mode. Some aren't, and those we can come up with alternatives. Or we might have to say that, well, this might not work in our MRI scanner here, but it can work with one, an hour away down south where they have a different scanner that can accommodate this. So usually we're able to work with everybody to find either our way to do it here or a way to do it someplace close by.
I have tried a few medications and they have helped a bit. I don't like the side effects. We hear that a lot, right? Even though they have helped. Would this be an option for me, even though meds help a little?
Yeah, so as long as you've tried the meds, if they have side effects that are not tolerable, or if they're not helping enough and you're still finding the tremor to be disabling, then yeah, this is still an option for you. If the medicines don't have many side effects and they're working great, then you probably don't need the focused ultrasound. But if they're causing these intolerable side effects that are ruining your quality of life, then it's not worth it. And this is what focused ultrasound is made for, that kind of problem.
And I think this is one of the things that another question that we often hear is, who makes the decision or how do I know when it's time to get this procedure? And I think that's what's great about this procedure. It's between like you discussing with the patient and deciding together, yeah, it's time and it's individualized, right? Everybody's not the same. There's not a specific test that they have to pass in order to get this.
Correct. Yes, yes. There are some of those insurance criteria where you have to try some meds and have to have a real tremor, but we go through all those with you, and everyone has, we'll discuss about all the different thoughts and pros and cons before we make any decisions.
Perfect. I'm about to have focused ultrasound for the second time on the same side. How often does it need to be done for second time? First time only lasted about 6 weeks before tremors started coming back.
Yeah, so that can happen, unfortunately. It's happened to some of my patients too. Fortunately rare. What happens is that when we're trying to hit that part of the thalamus, the VIM, we want to make a little lesion right there that can stop the tremor, but is not so big that it causes permanent numbness or permanent balance problems. So we're trying to find one that's big enough to stop the tremor, but not so big that it causes problems. And sometimes because of that Goldilocks zone problem, we make it a little too small. So it's when we first put it down, the tremor goes away, but it kind of just did some stunning of the tissue we really wanted to hit, and we should have made it a little bigger. So we can always go back and make it a little bigger. You can never go back and make it smaller. So that's what will cause most of those times where we have to go back and do it a second time. So unfortunately, it does happen. We're still doing a lot of research to try to find ways to more accurately predict exactly how big that lesion is going to be when we're done. But there's still some art to it. And that's responsible for some of those the redo treatments we have to do occasionally.
And is there, Dr. Wilson, is there a time frame if you do it one time and you have to go back in for the second time? Is there a time frame you have to wait? between those two?
Yeah, usually just a few months. So
Okay.
usually you do it the first time, and then if you see the tremor come back early, just a few months to before you try again, to
Okay.
make
And
sure
then
that you're otherwise feeling good.
to piggyback on that, you go
Mhm.
in and you do the first side and you decide this is great or whatever, and I want to come back and do the second side. Did you talk about the time frame that is?
Yeah, yeah. So there's after the big clinical trial they did to do the second side. So after you do your right hand, for instance, and go back and want to do the left hand, the FDA approval for that is 9 months waiting between the two sides. So that's what we do here. We usually wait 9 months to a year. And that means you have time to recover from the first one. Any side effects that you might have are usually gone. And then you're ready to approach that next one, full of vigor and health, to make it a smooth recovery for that second side too. So 9 months minimum.
Okay, perfect. How many times can I do focused ultrasound? Oh, does it help both hands? So we kind of just talked about the
Yeah,
first and
exactly.
the second.
So you can do it as many times as you want to. Hopefully, you just need it once on both sides. So once for the left brain, right hand, because the brain controls the opposite side of the body. And then about 9 months to a year later, you can do the other side.
Perfect. Is this procedure a possibility for someone with cervical dystonia?
Yeah, so cervical dystonia is not a tremor, but it's a kind of pulling of the muscles on one side where it can make the neck kind of pull over to one side. We often will treat that with DBS. There are some people that are experimenting with doing it with focused ultrasound, but it's very much at the experimental level. So you'd have to find a place that's doing a clinical trial or willing to do an experimental therapy for that. Otherwise, DBS is the main treatment for cervical dystonia.
So to piggyback on that, the next question is, and this is a great question because unless you are the DBS wires or connections, are they external or internal? Where are they once
Yeah, so
they?
it's a good question. So for DBS, deep brain stimulation, all the wires and batteries are under the skin. So you don't see anything. It's all under the scalp skin. The wires go kind of behind the ear, down the neck skin. You will, if you were looking in a mirror, you would see a bump in your chest where the pacemaker is. So if you're wearing a bathing suit or out with a low cut top, you'd see that. And then you might also, when you turn your neck, see the wires tent up the skin a little bit, but everything's under the skin. There's no exposed wires anywhere.
All right, we're down to our last two, it looks like. And these are a little longer. So I am 77 years old. 2 years ago, I had major spine surgery, base of spine, 23 titanium screws, 4 by 6 inch titanium rebars, sacrum to pelvis. Still experiencing moderate ambulatory issues. Is there any chance they're still a candidate?
Yeah, so maybe. So one of those things where we'd want to see you ourselves and evaluate you, or any of the other places that do focused ultrasound. The spine surgery itself doesn't make you less of a candidate. The thing that I would want to talk to you about probably is your mobility, because we worry about making your balance worse after focused ultrasound for a few weeks or a few months. If your balance is already bad, if you're having difficulty walking, we'd have to think about if it's worth making that worse temporarily, to make that recovery a little harder, versus waiting until you have a little more time to recover from the spine surgery so that you're more optimized going into the focused ultrasound. One of the nice things about focused ultrasound is it's not going away as a possibility. You can't age out. You can't be too old for it. So if you're a candidate for it now, you're going to be a candidate for it a year from now. So there's no real urgency to get it done immediately. So if you need to work around things like other health issues, you can do that. And it's still going to be an option down the road.
Perfect. I think when I was there this week, I asked, and I think the oldest that you guys have done was like 94. When I
Yeah,
was
yeah.
talking to
So
someone and stuff.
90s. And I'm sure people
Yeah.
also have done even older than that. Yep.
Okay, this one's a little longer too. I have what I guess is a mild tremor in my dominant hand, but when I write, I often can't read what I wrote. It varies with my mood, more or less anxious or time of day or practicing before writing. Would I be eligible for this? I have tried 3 medications with no luck. I do have varying problems with imbalance, and I'm concerned about the increase in imbalance. I'm 90 years old.
Yeah, so again, for someone like yourselves, we would see you and look at your tremor in person, and see exactly what's going on. There are other things that can make handwriting difficult besides tremor too. So we'd really want to make sure that it's tremor, not some other disease. There's actually a dystonia that can make handwriting difficult. So we want to make sure that we're looking at the right thing. And if we're convinced that it's a tremor and we're convinced it's something we can help, we would start going through the pros and cons of it. Again, B90 doesn't disqualify anybody, but we want to make sure that your tremor is something that we feel confident we can help. If we don't think we're going to help you, we're not going to offer it to you. We don't want to do surgery for no benefit, but taking a look at it ourselves with our own eyes is the best way to know how much we can help.
So with that, how long does it take to get in to see you, Dr. Rolston, approximately? If someone were to call that number that they see on the screen right now,
Yeah.
hopefully everybody's written it down. How long would it take for them to get in to see you?
Yeah, usually just a few weeks to get a clinic appointment. To actually get the procedure scheduled is usually a couple of months, 2-3 months in the future. We have a lot of people interested in this. We do a couple of days of this every week, and we do about 2 to 3 people. So those are the slots that are getting filled up. But this, yeah, give us a call. We can fit you in as soon as possible. And we'll try to. We're always trying to expand the number we can treat because there's so much demand for this.
Perfect. Well, we're going to end, but I wanted to give you the opportunity to have last words. And I want to thank you once again for taking time out. And it's your lunch hour probably to talk to the patients that joined us today. So with that, Dr. Rolston, final words.
Sure. So thank you for all your attention and for the invitation to talk today. Again, focused ultrasound, it's a newer treatment that we're all very excited about because it expands the number of people we can treat. People that were not candidates for deep brain stimulation or were too concerned or anxious about an invasive brain surgery can now be offered something that can be really transformative for their lives. And the fact that we've done so many patients is kind of a testament to how much demand or how much interest and hunger there was for another alternative treatment for something like tremor, which is so common in the people in this country. So reach out to us or any of the other centers across the world that are doing this procedure if you're interested and want to learn more. Thank you.
Thank you so much, Dr. Rolston. Thank you, everyone, for joining us. Have a great day.
And take care. Thank you.